Our technology is a real-time forecasting matrix for the Libyan migrant crisis. We are Alisa, Arush, Katie, Sophia, and Takumi.
To understand the problem, we must first look at the systemic barriers that exist in Libya. As of March 2026, Libya identifies over 939,000 migrants within its borders. This is a staggering 20% increase from previous years, driven largely by the ongoing conflict in Sudan. These individuals face extreme violence, extortion, trafficking, forced labor, and a fragmented healthcare system. The most dangerous aspect of the crisis in Libya takes place in the Saharan black holes. These are remote desert corridors where refugees are completely out of reach of traditional clinics or aid teams. Water, sanitation, and hygiene, or WASH services, are available. However, the lack of their infrastructure allows for highly infective pathogens such as cholera and polio to be constant threats in informal camps. Current technologies being implemented, such as the WASH services, are regulated by the International Organization for Migration, or IOM, which is the primary UN agency that manages the migration crisis in Libya. The IOM's health department is heavily involved in direct service delivery. They provide disembarkation assistance by the shore, give aid in detention centers, have mobile medical teams, help with voluntary humanitarian return, and also have a displacement tracking matrix. This DTM tracks migrant location, demographics, accommodation types, and priority needs. However, this system of reporting relies on human interview conducted every 6 weeks. In the harsh Saharan environment, groups of refugees can move, fall ill, and perish within that 42-day window without ever being recorded. This lag in data collection allows for pathogens to move faster than surveys. By the time a spike has been reported, the infection has already been spread throughout the transit network.
To bridge this gap, we engineered an anticipatory forecasting engine designed to turn those 42 days of silence into actionable intelligence. We aren't looking to replace the IOM surveys. Instead, we've built a predictive metadata overlay that sits right on top of the displacement tracking matrix. Our goal is to transition from reactive to proactive. By integrating the displacement tracking matrix baseline with pathogen data and satellite images, our engine can identify an emerging crisis and trigger an alert before an outbreak occurs. For humanitarian teams, this can buy up to a month of preparation time to pre-position medical supplies and water kits exactly where the engine predicts the peak will hit, rather than arriving weeks after the damage is done. In order to generate an alert, our architecture has to see through the Saharan black holes where traditional teams cannot reach. We can achieve this through a 3-layer data ingestion process. First, we have the space layer. We process Sentinel-2 multispectral imaging to remotely detect new camps or even changes in oasis water quality. Next, we have the ground layer. By deploying decentralized IoT sensors that detect pathogen DNA and water filters, we can collect biological data that doesn't rely on self-reporting. Finally, these layers are anchored by the DTM baseline data, which provides information about population and movement in between camps. By merging these 3 layers, we are able to transform static 6-week-old surveys into a live biological weather map.
The SIR model is a way to track people moving between susceptible, infected, and recovered. For cholera, the basic model isn't enough because transmission isn't just person to person, it's heavily driven by contaminated water. So instead of treating transmission as a constant, we adapted the model so that the transmission rate changes based on real-world conditions, especially water quality, sanitation breakdowns, and shared water access. At its core, the model follows a relationship like the differential equation on the screen, where beta represents how easily the disease spreads and gamma represents recovery. But in this case, beta isn't fixed. It increases when water systems are compromised, when there's overcrowding, or when populations are moving between sites. To turn this into an algorithm, each part of the model gets tied to real data. Susceptible populations come from estimates of crowding and water access, infected populations come from reported symptoms or cases, and environmental risk comes from WASH indicators like sanitation failures or water contamination. The system then runs in time steps, updating continuously. For each location, it calculates a transmission risk score based on things like current cases, water conditions, population density, and movement between areas. In Libya, specifically for Libya, instead of modeling the whole country as one population, we broke it down into locations like camps, detention centers, and neighborhoods. Using displacement data from groups like International Organization for Migration, the algorithm can track how people move and how risk spreads between these sites. The goal isn't just to count cases, it's to identify where transmission is likely happening right now, where it's going to spread next, whether cases are being imported or growing locally. Overall, the SIR model becomes useful when it turns into a system that updates with real-time data and inputs actionable risk, essentially functioning as an early warning tool for outbreak detection and response.
Any system that monitors populations has to earn the right to exist. We grounded our design in the four principles of health ethics. Starting with autonomy, our system was intentionally designed to avoid collecting data directly from individuals. The ground layer reads pathogen DNA from water filters. The space layer uses Sentinel-2 satellite imaging, where its resolution is high enough to identify housing settlements, but not high enough to resolve individual people, so that there is a layer of privacy built into the technology itself. Additionally, all data is anonymized at the sensor and satellite level to where it only reflects aggregate health risk across a region, not the presence or behavior of any specific person. For beneficiaries, the primary beneficiaries are migrant communities currently invisible to existing healthcare infrastructure. 42 days pass between DTM survey rounds. In that window, a cholera outbreak can sweep through an entire transit corridor undetected. Our system closes that gap and enables preemptive response instead of damage control. Non-maleficence is also where it gets harder. Any map that shows where vulnerable people concentrate is inherently dual use. Militias, smuggling networks can operate in the same corridors that we're monitoring. So our dashboard uses spatial blurring, where health risk is visible at the regional level, but specific camps and people are not targetable. Finally, justice. There's a real privilege disparity between us as engineers and the populations we are designing for. We address this by sharing data access with local health authorities rather than holding it exclusively. The goal is for this technology to challenge existing power imbalances, not reinforce them.
Looking at the implementation of our technology in terms of scalability, cost, and longevity, we plan on using affordable hardware, specifically long-range wide area network nodes. This would allow us to transmit data with low energy and low cost for our system to be scalable. And then also getting the local community involved, so training the refugees and host communities in the hardware maintenance that will allow them to have a better understanding of the system and why it may benefit them, as well as sustaining our technology.